Our next speaker also happens to be our host. Gianrico Farrugia is he's the director of the Center here for Individualized Medicine at Mayo Clinic. And I'm really excited because I think that he is going to bring us some real-life patient stories and take us into the world of practicing medicine and how you can begin to incorporate some of this very sophisticated science, cutting-edge science, into the practice. And he's going to share with us some of the experiences and the learnings from here at Mayo Clinic. Obviously, you're all here and you know that Mayo has been such a leader in this field. And so this is a really special opportunity to hear exactly how they've been going about it. And then we'll also get a chance to ask him about some of the challenges as they've moved forward in this process and maybe what the future holds. So please, let's welcome Dr. Farrugia.
Thank you. Well, welcome back. First of all, again, thank you for coming, and thank you also for being such an interactive audience. You know, sometimes people have to sort of make up questions. It hasn't happened yet because of all the questions that have been coming through. So we'll see how this goes. The other thing I want to say is we had a spectacular 2 talks this morning. So I can really say that on average, it was going to be a pretty good morning. What I was asked to speak about is what has Mayo been doing to take that promise of genomics, the promise of genomics I mentioned when I first came on stage, and transfer it into the practice of genomics. And that's, of course, what I'll do. So my objective slides mirror exactly that. Describe the role of individualized medicine in patient care, and then describe effective models to incorporate individualized medicine into the routine practice. Now, at Mayo, we're slightly different in that the Center for Individualized Medicine was tasked with not only research and education, but also with practice. So that means whenever there is an unexpected sequencing problem, it's a problem for the Center for Individualized Medicine. On the other hand, if a physician doesn't like the color of the button used to order an individualized medicine consult, that's our problem too. Now, that's the bad side. The good side of this is, however, we're much more integrated. And therefore, we're able to do what we're tasked to do, which is to discover and integrate the latest in genomic, molecular, and clinical sciences into personalized care for each Mayo Clinic patient. The way we set ourselves up to do is through these 5 translational programs. So there are 5 translational programs, and I'm going to speak about each of them, that each have their own research, each have their own translational arm, and each of them have their own clinical arm. But they also serve another important purpose. And that important purpose is to take a lot of that clinical information and focus it down on our economics program. And our economics program is really where the patient interface happens most of the time at Mayo Clinic. And it happens through something called the Individualized Medicine Clinic. And it's happenstance that yesterday was the 1-year anniversary from the opening of the Individualized Medicine Clinic. It was the And to us, that was a really major event. It was where we transferred and we said, OK, we're ready. We're ready going to do this on a clinical basis while we continue to do the research. So my first question I have for you today is the following. So I'd like you to answer this with the software that you have. I've been involved in patient care and I've used results from gene panel or whole exome or genome sequencing never, 1 to 2 times, 3 to 10 times, or 11 times or more. And so you can see there, as we update, it's nerve-wracking watching the seconds tick away here while I wait for you to answer. So I've asked this question, I think, for 2.5, close to 3 years. Never is always the most common answer, but it keeps shrinking. And this is the first time I'm seeing the yellow portion. We have never seen that yellow before, that 4%. suggesting that over time we're beginning to see how this is getting to really touch our patients. Now, when we set up the individualized, next slide please, when we set up the individualized medicine clinic, we had to make a decision. And our decision was, are we going to embed genomics and related omics into a particular department, or are we going to do it above the departments? And we decided to take the above the department approach. We did that because we realized that departments, be they research or clinical, are really good at having that infrastructure to do what they're supposed to do. But when you get to genomics, when you have to create a completely new infrastructure, that sometimes can be an issue. So we wanted to raise it above the departments, and that's why we created our individualized medicine clinic. We also realized that within each department, there are some people who are really smart, really focused. But you can't run something that is institution-wide without having a multifaceted expertise. And so we needed a mechanism to bring people out of departments into a separate place where they can communicate outside of their departments. Having an individualized medicine clinic also allows us to have well-defined patient selection criteria, which for us was really important. If you get into the door in Arizona, if you get into the door in Florida, if you get into the door in Rochester, we want to make sure that the criteria for selection of who goes where are identical in each of the places. And of course, we wanted to make sure we had the opportunity to create the infrastructure and the coordination for a cohesive approach. So what happens if you get referred to an individualized medicine clinic? We have all our patients meet with genomic counselors, and we feel this is critical. So in individualized medicine and personalized medicine, we always talk about the ability to tailor prevention, tailor diagnosis, tailor therapy. But we strongly feel that we also need to have the opportunity to also tailor our approach to the individual. And that includes what results to give, what results not to give, let people go through that journey of really understanding what the process is about. The reality is that we also need to offer financial counseling. You've heard this morning, you heard yesterday, is that it's not easily reimbursable. Reimbursement happens, but it happens in piecemeal fashion. And up front, it's very hard to understand at the end of the day what the patient is going to bear. And we have examples where that has been less than $1,000, and we have examples where that can be over $11,000. And therefore, we need to have that conversation. We needed to make sure that extraction and processing of DNA was standardized. And that's really important. The radiologists need to know how many biopsies to get. The surgeons need to know the type of biopsy to get. The pathologists need to know what are our criteria for cellularity, what are our criteria for tumor heterogeneity. They're all things that we needed to fix up front. And for DNA, you can also change that to RNA as well. We created a bioinformatic team that was separate from bioinformatics at Mayo, but integrated to make sure that we're providing that focused expertise we need where we're fairly early in this journey. And of course, we created boards. And they're the boards you heard Elaine talk this morning. Our tumor board has been running for a year and has our Genomic Odyssey board. They're the boards that come together, bringing all these people from different subspecialties into one place. So how does it work? There are 3 ways of getting into our individualized medicine clinic. The first is the same way you would do if you had a patient that you want to refer to gastroenterology or to cardiology. You can go on the EMR, click I am clinic, and that's how you get the referral into the clinic. The second is our increased social media presence, our increased website presence is creating a portal for patients to directly contact us. The third is interesting because it's picking up, is e-consultation. So we all know it's early days, but it's also clear that the new generation of oncologists especially are very aware of the power of genomics. Sometimes they're more aware of it than their own institution. So many oncologists know what they want to do, know what results they need to have, but they don't have the infrastructure to get what they need to get done, so they contact us. But at the same time, they don't want to lose, as they shouldn't, autonomy and control over that patient-physician interaction. And so by e-health, we're able to connect with them, bring them as part of the group so they are still part of the care of the patient even as they go through this process. Once that happens, as I said, genomic counseling, we always assign one physician to be the cheerleader, sort of the director of that encounter. We have the tumor board or the genomic board that conducts a preliminary review, and then we go along and we sequence. Once we sequence, results come back, get analyzed. We've worked really hard to make sure that the report can fit in 1 to 2 pages. Once the report is there, it's presented to the board. We bring in other information as we need. And then the chair of that board is tasked with creating one report. So there's only one report that goes in the medical record. That way, there aren't 4 or 5 conflicting reports with some slightly different suggestions. So that report, of course, reports back on the findings, possible action items, and what else can be done for that patient. So at the moment, we see 2 subtypes of patients. I'm going to give you an example of each. Here's the first. It's for patients with advanced cancer. Let me take you through this, and then I'll make a couple of points. So for those of you who, I'm sure most of you know, but for those of you who don't, cholangiocarcinoma is a tumor of the bile duct. The bile duct is where bile leaves the liver and gets into the gastrointestinal tract. Once a tumor invades the wall of the bile duct and passes through the wall, unfortunately, it's uniformly fatal. We've had 6 patients come through our clinic in Arizona and in Rochester that happen to have a cholangiocarcinoma. And what we found is that 3 out of those 6 patients had a fusion gene. And that fusion gene always had as one of the 2 genes fibrous growth factor receptor 2. And that fibrous growth factor receptor 2 could fuse with either another part of the same chromosome or a different chromosome. And that, of course, resulted, because of what it is, a tyrosine receptor tyrosine kinase, then that resulted in uncontrolled proliferation. So this is one of our patients. And that patient, by the time she came to us, was already in a phase 1 trial for pazopanib. And that was not because of the fibrous growth factor receptor, but as you know, it has some effect on receptor tyrosine kinases. And in fact, you can see, and I don't have a pointer here, but if you look onto the left of the screen, you can see some response. But the patient progressed, and you can see more disease on the right. And that's when she was switched to panotinib, which is much more selective. And on that, there was tumor regression, and now, at this point, is tumor stabilization. So I make this point because these are the kind of people we're seeing. So what are we seeing? About 55% of the time, we have an actionable item, which can vary, but it's an actionable item. What we struggle with is now, yes, okay, drug availability, all the rest, but what happens next? So for patients with advanced disease, there is uniform agreement. This is something that can benefit patients sometimes. But now, what about the next step? Those patients who, at the time of diagnosis, you know that conventional therapy is not particularly going to give you a good result. And there again, we're beginning to see somewhat of a shift where people are beginning to think that that may also be appropriate. What becomes an issue is when we go to the third part, which is when you do this at the time of diagnosis. And therefore, now you have a situation where there's conventional chemotherapy and you have targeted approaches, and we have no way, because we don't have the trials, of figuring out if it's best to do in parallel, do them together, do them one after the other, which comes first. And those are the questions that are going to be the art of medicine, because it's highly unlikely, given the targeted approaches, that we're going to be able to run large phase 3 trials. The second patient we see is this patient here, and I specifically chose this example because it was shown to you yesterday. So I'm going to very briefly go through it for those of you who are there outside getting coffee or were in the restroom after having gotten coffee. And what this is the patient that came to Mayo Clinic, Florida, and said, look, I have kidney disease. My father has kidney disease. I'm now married. I want to know what my kidney disease is, and I want to know how this is going to affect my kids. And as you heard yesterday, we sequenced that patient, his brother, who was unaffected, and his father, and found a fibronectin mutation that has previously not been described. We're in general agreement that for these cases, this is really well-suited technology. However, most of our patients don't fall into this category. They fall into a category of either having complex chronic diseases, which one can consider the opposite end of the multigenetic, the single gene disease. But then we have this gray area in between, where there's a strong family history, but it's unlikely you're going to find a single gene. And this is where I think, after a year of experience, that we need to sit back and start to think and collaborate everybody around the country and figure out, as we continue to do this, because we have to continue to do this, how are we going to create new bioinformatic models that don't assign a particular fixed value to a particular variant, but rather assign a moving scale value that very much depends on the background, very much depends on what other variables are present. And that's something that clearly is going to require collaboration between every center around the country and around the world, because I even don't think there's enough within the country that will allow us to do this on our own. The second program I want to talk to you about is our biomarker discovery program. With the advent of next-generation sequencing, it has now become possible to accelerate biomarker discovery. So with that preamble, I'm going to ask you the following question. So the question is this: approximately how many biomarkers have been approved by the FDA over the past 20 years? So this audience is either very good at test taking or is very knowledgeable. Because the answer is actually around 30. And that is a significant issue for us. A significant issue is the pathways for biomarker discovery to get into FDA approval is quite tough. Now, having said that, we are making significant progress. And through our biomarker discovery program, we've been able to advance, and can you go to the next slide, please? We've been able to advance certain biomarkers for different diseases I'm going to show you on the next slide. And here they are. But I also want to use the slide to make a point. These are just some examples. They were all discovered using platforms that were next-gen sequencing based. But then look at the testing platform. The testing platform reverted back to our standard mechanisms. And this is where I think we collectively have to do a better job at pushing regulatory governmental platforms to be able to come up with reasonable guidelines that allow us to do what we need to do for our patients. But the tide is indeed turning, and one of the ways it's turning is into these specialized gene panels. An example of this is Mayo's first next-gen sequencing-based gene panel developed in collaboration with our Department of Laboratory Medicine and Pathology. It's 17 genes that are there for somebody who's suspected of having hereditary colorectal cancer. This has been live for the last 3 months, and we've already had patients who, through this panel, have been diagnosed as having hereditary colorectal cancer, which we would not have through the old methodology. And that, of course, has significant implications both for surveillance of the patient as well as screening of relatives. And the interesting thing about this is that the gene panel, though still spendy, cost about the same as 2 of the genes we've done individually by the old mechanisms. And of course, we all know this is where we're going to see a lot of things happening in the next 2 years. We're going to see gene panels because they're a little easier to validate, and therefore going to see these come in first before the next rush of the exome and the genome. But not all biomarkers should be blood. Not all biomarkers should be tissue. This is an imaging biomarker that was developed with Dick Heeman and colleagues in radiology. So this takes advantage of a technique called magnetic resonance elastography. And this technique was developed in 3 dimensions to be able to get full coverage of the liver. What it allows us to do is determine the stiffness of the liver. And because it's in 3 dimensions, is able to determine the stiffness of a nodule within the liver. We therefore don't need to biopsy in most cases to find out about liver fibrosis. And it's happening. The amount of liver biopsies that have been going on at Mayo Clinic have decreased dramatically in the last year or so. The third program I want to discuss is our pharmacogenomics program. And of course, you heard a great talk earlier this morning about pharmacogenomics. So I'll start off with a question. You heard the talk, so now answer this question. Should all patients undergo prospective genotyping for pharmacogenomic variants before drug prescription? So it's yes, no, only for selected drugs, and only after an adverse reaction. It's hard to believe that there was only a yes and only for selected drugs, but maybe because those tend to be quite polar opposites, but I guess that's what you decided. Our approach is only for selected drugs at the moment. And it, I think, mirrors a lot from what you heard earlier this morning. I'm going to give you some examples of this. So the whole issue here is now that we know there are about 80, 84 genes that are responsible for a lot of that so-called idiosyncratic reaction, what do you do with the data? The question is, how do you get the right drug at the right dose at the right time for the individual patient? And our answer is we've got to embed that information into the medical record. We have to do it such that there needs to be some but very little education, because it can happen at the point of encounter. So if you look at where we are at the moment, in green are the 3 drugs that at the moment have a decision tool, a drug gene rule embedded in our medical records across our sites. In red are the drugs that this is going to be happening now, this coming week, and in blue are the ones that we're still working on. An average physician-patient encounter in the United States is between 13 and 17 minutes. An additional click of a mouse is an issue for most physicians. Therefore, you have to find a way of making sure that the information that is given is not only correct, but also done in a way that is easy to use. So one of the decisions we made is that we're not going to use the Center for Individualized Medicine to make that decision. Rather, we formed a pharmacogenomic task force that did not report to us, but rather reported to the Mayo Pharmacy Formulary Committee. This task force interacts with the clinicians, creates the material that then is either approved or disapproved. Then only once it's approved is the Center for Individualized Medicine coming in together with our colleagues in IT to make sure the rule is embedded. And this is what it looks like. This is for a drug called abacavir. Abacavir is an antiviral. What's important to know about abacavir is that if you happen to have a genotype called B5701, you have an 85% chance of a severe life-threatening side effect. So if you now at Mayo try to order the drug, this is what the screen comes up as. It's a different color in different sites. And what it tells you is that don't order it until you know the genotype. And then you can see at the bottom the Ask Mayo Expert. So that's the point where we provide information to the provider. If you click that, it gives you FAQs. It also tells you what is going on. This has been going on now since January, and it does work. It's fired, as you can see, quite a few times. There are 14 patients at Mayo Clinic that would have normally gotten the drug that did not get it because the genotype turned out to be positive. And 85% of 14 is somewhere between 12 and 13. That is really important for those 12 to 13 patients. You heard this morning about CYP2D6, and that's where we're going to next. These are results from our biobank, and you can see the upper part. Those are the ones that are more likely to have an unintentional overdose. That's important to the painkillers. But then also look at the bottom part. Tamoxifen is also through CYP2D6. If you're a woman making a decision about breast cancer, then knowing your CYP2D6 may influence your decision to take tamoxifen or not. Now, part of this is implementing what we know. But the other part has to be investing in what we don't know. And there are 3 clinical trials we at the moment have going on in pharmacogenomics that are Mayo's investments to answer what we consider to be critical questions. The first is this one, Beauty. It's for patients with advanced breast cancer. It's our first one, and I'll walk you through it. If you enter the trial, you get your tumor sequenced, and you have, of course, your own blood sequenced. You then get some advanced imaging, and then we create a xenograft on the mouse. You then get into neoadjuvant therapy. Halfway to neoadjuvant therapy, you get sequenced again, the tumor does. And then for those 80% who still require surgery, at the time of surgery, tumor gets sequenced again, we create a new avatar so that we can start to answer some of the questions we need to answer, which is, what's the best neoadjuvant therapy? Why do some people get a complete pathological response and some people do not? Last month was a critical time for the study because we passed the 100-patient mark. And with 100 patients enrolled, we now switch to the second part of the study, the truly adaptive clinical trial design, where we take what we learned for the first 100 and apply it to the second 100. This approach we're also using for our second trial, which is on prostate cancer. Most of you know men get prostate cancer. It's an indolent disease. Most of us will die with the disease, not of it. Despite that, when you go then and look at the statistics, prostate cancer is a significant cause of death in men. Why? Because there's a subset that really do poorly. So we want to know, can we use a pharmacogenomic approach to tailor therapy? And this is the PROMOTE study, started about 2 months ago. Takes men with castration-resistant prostate cancer and does something very similar to what I showed you for breast cancer, including, however, a little more now, since it's our second trial. We learned a little more in the epigenomic space. They get 12 weeks of bitarone, and then they either respond to it, keep going, or they change drug. And again, first 100 in, second 100 will change according to what we learned from the first 100. It's not all about cancer. And the last clinical trial I want to highlight is this one here. And you heard a little bit about it this morning. You heard a little bit about the issue yesterday, which is what do you do, what drug do you prescribe after a stent has been put in a coronary artery? This is an issue because the FDA says we need to know the genotype. The American College of Cardiology respectfully disagrees. That leaves the physician and the patient a quandary. And that's what we're trying to answer in the study. So this is a 6,000 patient study. Once you're in it, you're randomized to either go to the conventional arm, where you get conventional drug, and then 12 months later, we have collected the sample, of course, and then we sequence, and we find out if you're wild type or you carry an allele that makes you less likely to respond to Plavix. The other part is the prospective arm. While you're in getting your procedure, in 55 minutes, we can get the result, and then you get randomized into either Plavix, or if you're not going to respond to Plavix, into another drug. This is taking us a lot of partners in Canada, in Korea, a lot of our Mayo Clinic partners that are involved in this to be able to give us an answer within a time period that makes a difference for our patients. The next I want to talk about is epigenomics. Let me actually not, rather than introduce it, let me start off directly with a question. So this is the question, and epigenomics is a field of study focusing on what? And here are your choices. And again, for test takers, the answer should be obvious. And I wish, having to take my boards every 10 years, that questions come up like this. Okay, let's see the answers. If anybody gets it wrong at this point, God. All right. So the point I really want to make with this simple question is how rapidly epigenomics has gone from a fringe science to dominating life, both from a research standpoint, but also what's going on clinically. It is remarkable. And I want to give you a few examples of some of the studies, 3 of them, that have been going at Mayo Clinic that directly hit our practice. So this is a really interesting study from Dr. Zhang. And what he did was he looked at a type of a brain tumor. It is likely applicable to many other tumors. This particular brain tumor, in it, there's often a mutation in a histone 3 variant 3. And that mutation I'm showing you there is K27M. What was found and mirrored an earlier study is that as a result, now there are 2 genes that are responsible for making that histone. Despite the fact there are 2 genes, despite the fact the mutation is on one allele, if you happen to have that mutation, that particular histone, there's marked loss of methylation. And even more interesting, and this is what was the novelty here, is that the net result was that in tumor suppressor genes, there was an increase in occupancy. So there was increase in methylation, when other genes there was not. And it's really interesting to see how this very specific defect can have this remarkable effect on gene expression. And it really highlights to us that as fast as we go, we can never go fast enough. We just caught up with the exome. We now have to deal with the genome. We've got to deal with the transcriptome. We're not going to get to where we need to get to unless we're incorporating epigenomics into patient care. The second is from Dr. Ordog's group. And this is also a tumor. It's a gastrointestinal stromal tumor. What Dr. Ordog found out is this incredible communication between the membrane and the nucleus. So what they found out was that if you take insulin growth factor receptor and insulin growth factor 1, which is the ligand for the receptor, that is expressed on the gastrointestinal stromal tumor cell, results in the activation of AKT, phosphate AKT, inhibition of G3SK1, and that inhibition results in remarkable changes at the level of the gene that is responsible for resulting in KIT ligand. And once you have KIT ligand, it can either act on that particular cell or on neighboring cells, so an autocrine or paracrine effect that then drives to the KIT receptor, which is, of course, highly expressed in cysts and results in increased growth. Again, another epigenetic mechanism that is responsible for cellular proliferation. Again, to make sure we understand, this is not all about cancer. The last study I want to highlight is the study from Dr. Farrugia's group looking at maturity onset diabetes of the youth. And maturity onset diabetes of the youth is a particular type of diabetes often associated with mutation in KLF11, Krupfel-like factor 11. And what they did is that they did whole genome expression in beta cells to see why would a mutation in KLF11 result in diabetes. And what they found were two important findings. The first was that baseline insulin secretion was altered, and the second was that the response of insulin secretion to glucose was also altered. So here we have an epigenomic mechanism that results in alteration in a metabolic pathway giving rise to diabetes. Okay. Moving on to the last translation program, the microbiome. At Mayo Clinic, we made the decision that there's no reason why we had to be elitist. That, in fact, bacterial genomes respected the same, we should deserve the same amount of respect as our own human genome. And in fact, as we all know, there are 10 times more likely, there are 10 more cells than there are human cells. So we decided to incorporate the microbiome into the Center for Individualized Medicine. Here's the question. The intestinal microbiome is not implicated in which of the following human conditions? Colon cancer, obesity, rheumatoid arthritis, alopecia, or diabetes? Right, those are some quick answers. So the answer is, in fact, alopecia, but the reason I have this question up here is just to make the point how rapidly this field has grown. And in fact, I would suggest to you that what you've done is given Jeff Gordon his next science paper, which is the role of the intestinal microbiome in alopecia. We're all aware it's not one microbiome, it's many microbiomes. Yes, in the GI tract, but also in the mouth, in the skin, airways, urogenital tract, the blood, in our eyes. And each of those microbiomes, yes, live with us, but they also keep us well, but they also make us sick. Increased understanding of the role of the urogenital microbiome in kidney stone formation, of the airway microbiome in chronic airway disease, of the potential of the skin microbiome in postoperative infections. You can keep going down the list. There are at the moment 18 diseases that we're currently studying at Mayo Clinic linking a particular microbiome to a disease. And I'm going to highlight 3. This is a really interesting study. Came out from our really good collaborators in the space, the University of Illinois Champaign-Urbana. And I have to mention them. There are 50 people got onto a bus to come here. So thank you. But what this question was, what the study was meant to answer was the following. How does a microbiome form? How does it remain stable? Does it in fact remain stable? And there are at the moment 2 competing hypotheses. The first is the niche theory, that the microbiome forms because of a complex interaction between an individual bacterium, a species, the environment, and the host. The other one is the neutral theory, where this is way much more a stochastic process. And it's a stochastic process that can be altered by a particular invading species. Both can be modeled equally well. So the question was, which of those 2 is right? And what the investigators did is they took 2 identical pigs, cloned pigs, 2 cows fed at exactly the same time, and 2 chicken. One was just left alone. The second was inoculated with C. jejuni as the invaded organism. In red is what you'd expect to see if the neutral theory was correct. And in blue is what you expect to see, and it was indeed seen, if the other hypothesis was correct. So this suggests that the niche theory is what drives the stability of the microbiome. And this is very important for us as we begin to think of ways of disrupting microbiomes and reforming them. The second study is the study upon rheumatoid arthritis. There are two types of mice that were studied in the study. One kind of mouse that was associated with development of arthritis, reactive arthritis, and the other one that was not. The two microbiomes were studied, and two really interesting findings came out of this. The first was that the microbiome in the two mice was different, but the second was that the gender difference that you normally see was not present in the mice that had an HLA type that predisposed them to reactive arthropathy. And this, in fact, has resulted in now moving this forward from the mouse study to a human study. The last study I want to highlight is this big issue that is really important to answer. What's driving our microbiome? Is it genetics? Is it our diet? Is it a combination? Is it the host genes? Is it the bacterial genes? So what Dr. Perna Kashyap and his colleagues did is they took advantage of the fact that 20% of us lack a gene that results in fucosylation of mucin. And mucin is a good dietary source for bacteria. So they took a mouse that also had that same lack of abilities. There's a FUT2 knockout. You either had or you did not have it. And you can see on one side in blue, the mice that didn't have it. On the other side in green, the mice that have it. And then they asked the following questions. The first was, what was the difference in the microbiomes? And in fact, there were specific differences. But the second really interesting thing is they took a germ-free mouse, inoculated it with one species, B-theta, and then fed it a polysaccharide-deficient diet. And when they did that, they found that diet overrode the genetic influence, suggesting that we really have to keep in mind diet, gastrointestinal genes, bacterial genes, as well as motility and transit, as we look at a more comprehensive approach on how to use ways to influence our intestinal microbiome. Now, the way that this is hitting the practice soonest is through C. difficile colitis. I apologize for those of you who know this very well, but for those of you who don't, C. difficile colitis is an inflammation of the gut that you get when your gut is overrun with a particular organism called C. diff. You can get it by happenstance, but most of you get it on exposure to an antibiotic or after you've been in a nursing home for a prolonged period of time or in a hospital for a prolonged period of time. It's treatable, but not everybody responds. Every day in the United States, 40 people die of C. difficile colitis. So our approach in Arizona, in Rochester, and soon in Florida has been to do a twofold trial, one a clinical trial as well as a clinical, just as a clinical application, and then one as a research part. The clinical application is this. We're doing fecal microbiome transplants. We've done over 75 this year. It's remarkable. There's over a 90% success rate, and the symptoms, so these are patients who've gone through every therapy. So by the time they're at this point, they're either bedridden or they're close to being bedridden. 1 to 3 days later, they feel practically normal. And what we're finding from our research labs is that the microbiome is in fact engrafting in the donor stool. Now, up to now, I've spoken. So this is where I'm going to take the opportunity that one of our patients who had this done was kind enough to share her story. So I'm going to share that story for the next minute. And maybe you can roll the video at this point.
I've been a paraplegic for about 10 years. And with the love and support of my family, I've learned to live independently. But then I developed a serious intestinal infection. I lost all of my independence. I couldn't leave the house. I missed all the family holidays and celebrations.
Ms. Shea suffered from an intestinal infection called Clostridium difficile.
It's a huge medical problem. Every year, about 500,000 to 1 million Americans suffer from it, and there are 14,000 deaths due to it. It is often resistant to antibiotics and sometimes very difficult to treat. That's why we need medical advancements and research for its treatment.
Our bodies are home to 100 trillion microbes, mostly bacteria. We can't see them, but with the modern genome technologies, we're better able to understand how they impact our health. In patients like Ms. Shea, we are beginning to understand just how important the balance in these populations is.
I battled this infection for over a year. I was too tired to do even the simplest things. I decided to go to Mayo Clinic. Dr. Connor told me about a procedure that sounded promising. Just 2 days after the procedure, all the symptoms were gone. I had my life back. It was a miracle.
The procedure Ms. Shea received is called a microbiome transplant. It is administered during colonoscopy and restores the natural balance of microbes in the gut. The success rate of this treatment has been 85 to 95%, and the majority of people get better in 1 to 3 days.
We're starting to understand that small changes in this incredibly diverse and rich population can have profound and far-reaching impact on our health. This research is changing how we detect, diagnose, and treat disease. We're integrating science into practice so we can offer new hope for our patients.
First of all, I hope you heard it better than I heard it up here. I show this video just to make the point of what's driving us. What's driving us is, yes, the promise, the excitement, but the fact there are patients that continue to need help. Now, there's actually another happy ending to the story. And if you could show the next slide. 3 weeks ago, she was asked to throw the first pitch up at a Twins game, and she invited a lot of the team to come with her, and here she is at the Twins game. And I am not going to spoil the story by letting you know the results of that game. Okay, I'm going to start wrapping up. As I wrap up, I need to make this point. What have we learned in the last year? We've learned that you need dedicated teams, and you need a really robust infrastructure. This does not happen in a vacuum. There are things that had to be done at Mayo that we had not been done for several years that were essential for us to be able to move from promise to practice. Biobanking and biorepositories are essential. Having well-annotated samples that you can access that are stored in ways that are research-grade and clinical grade. You've heard yesterday, you've heard today, and I hear it again from me. Biomedical informatics, IT are essential. You got kids, there's a good place to tell them to get into. There's going to be a job for them for a long time to come in the future. You need a medical genome facility that's ready to incorporate the latest in sequencing technologies, but also we made the decision that we're going to have that research facility use standard operating procedures that are clinical grade so that that transfer into the clinic happens much faster. You need a really strong bioethics program. We are at the edge of what science can do. And whenever you're at the edge, you can go one of two directions. And be able to have the expertise that we have here, Jen McCormick, Dr. Sharp, many others who are here to caution us, to tell us what we need to learn, what kind of information we need to do before we do anything is really, really important. And you need a really strong educational program. And some of the questions this morning came into this. You need an education program that is able to take the information and make it available to the provider, to the patient, but also to everybody at Mayo Clinic to make sure everybody understands why we're doing this and how we're doing it together. And in fact, today is the launch of a series of online courses that were created specifically for pharmacy technologists to make sure that they too have that information as well as pharmacists to be able to deal with the issues that come with drug-gene interactions. So I'm going to stop here. Before I stop, I do want to say something. The Center for Individualized Medicine at the moment, around 300 strong, is a remarkable group of individuals, and therefore I want to give a shout out to them and tell you thank you for everything you do. It doesn't work in a vacuum. The whole of Mayo Clinic has made this a priority, and we know that if we look back at the past year, there's a ton of work that has been done. We know there's even more than that that needs to be done, but I think it's fair to say that we are moving from promise to practice. Thank you.
That was wonderful. I don't know about others in the audience, but I felt that there were some really encouraging data points that you had for us. I mean, the first thing that struck me, Gianrico, was compared to a year ago when we were here, you were talking about real patients and real patient stories. And that to me is progress. I also was a little surprised when you asked the question about how many FDA-approved biomarkers there are. I guess I was in the pessimist camp. I was in the 10 range, and 30 really is quite remarkable.
Yeah, you're the host, but I guess I should differ.
No, you're the host.
No, 30 over so many years isn't that good. It's about 1.5 a year. That's not very good. We've got to do better than that.
And why then is it not as good as it should be?
The obvious answer should be that darn government. But no,
That's what I was wondering.
No, but it's not that simple. There are many reasons for it. It's the fact that we as a group want to make sure we do the right thing. And that involves us making sure there are many hoops to jump through. It's also because it is really important to bring clinicians into biomarker discovery right at the very beginning. If you bring them in with, here's my biomarker, I think it's wonderful, go use it, you really don't get much of a response. So the effort really has been in our biomarker discovery program is to ask the clinicians, the pathologists, the surgeons, be part of that group. You may think you don't have a lot to contribute early on, but having just the ability to say, that makes sense, that doesn't make sense to me, makes a very big difference.
Sure. You closed with a phrase that I love, from promise to practice, and several people in the audience have sent questions on this general theme of what have been your toughest challenges to actually move from research to practice.
It's very hard to point at one challenge. I think it's really, I look at it as building a new department. If you were building a new department, you'd have to really build all the building blocks to make it happen. So it was equally difficult to make sure. I'll give you an inane example. We had to name our Individualized Medicine clinic. So, of course, what do you name it? CIM, Center for Individualized Medicine. Well, CIM means community internal medicine for everybody else. So that was a hurdle that had to be passed. So it's not like there was one insurmountable hurdle. It's not like in biochemistry where there is this activation barrier. You pass the activation barrier and you're done. But rather, it's a series of hurdles that are sort of designed to weed out the weak so that only those of us who are just really obsessed can get through to where we need to get to.
And I gather that you really obsessed folks. You've got scientific hurdles, clinical hurdles, bureaucratic hurdles, naming hurdles. I mean, it runs the gamut. It's not just the science and medicine.
Yeah, the science and medicine are actually probably part of the easier part. It's all the rest that requires a lot of interaction.
And a related question, someone's wondering what your funding stream has been and is it sustainable?
So Mayo made the decision 2 years ago, to Dr. Nosworth, who was here introducing the conference yesterday, that the 3 strategic priorities for Mayo Clinic were regenerative medicine, science of healthcare delivery, and Center for Individualized Medicine. And because of that came with it the funding necessary to make this happen. So the funding really has come from Mayo's sort of ability to do this in partnership with our benefactors, who have been really generous in seeing the promise of individualized medicine and have sort of stepped up to help us fund this. We will continue to rely on that, but we are also exploring different ways of making this sustainable. Working really closely with industry to see what opportunities are there to accelerate change, bring things to our patients faster by creating commercial opportunities, as well as looking at different spaces, including federal funding, though that's not something I want to mention today.
Okay, we'll hold off on that, especially since the government's closed today. So we probably couldn't even reach anybody if we wanted to call and ask them. Another question from the audience. You said that you turned the development of drug gene rules to a task force and suggested that the proposed rules could be rejected. Elaborate a little bit on that approach.
This is interesting. You could tell that the person who asked this question is not a Mayo person, because it asked, has this happened? And if you live at Mayo, yes, of course it's happened. Absolutely it's happened. There are well-meaning people who have very strong views, and that's why we like having people like that at Mayo Clinic. And their views are, I don't want this to happen until we're 100% certain that this is the right thing to do. And so this is where you go back and forth and you try and come up with the most reasonable solution. And sometimes it's to delay, sometimes it's to implement, and sometimes it's to hold off. A delay is, for example, we were convinced that one of the drug rules that we wanted to put in was for interferon. Our hepatology colleagues said, wait a bit, we know there are new drugs coming in that will make it irrelevant to have that drug, so why waste the energy of doing it? So we listened, and we've delayed this to see what will happen as those new drugs come in.
Okay, great. Talk a little bit about the genomic counseling process here. I believe in your clinic, genetic counselors perform that genomic counseling.
So as the genomic counselor are fond of telling me, they're really, really important. We've made the decision that every patient meets with them as the starting point. And very often they become the quarterback of the process. They're, as a group, a very empathetic group.
Empathetic.
Yes. They, as a group,
what
did I say?
No, I wanted to make certain we heard you correctly.
Because sometimes my brain says something and then... yeah. All right.
In case any of them are out there, we just want to underscore empathetic.
Yeah, and they also are very much engaged in knowing what patient needs are. They have the ability to draw fears, to draw questions out of patients that require a more a deeper conversation, a more serious conversation. So I think they've really been essential in the success that the Individualized Medicine Clinic has had. Now, one of the issues is that there aren't that many across the country. Genomic counselors, there aren't enough genomic counselors to fulfill the needs of genomics. And we're going to have to do, or both, ramp up to be able to meet the demand, but also come up with new ways of delivering material that doesn't necessarily always need to have a face-to-face encounter. Just simply, it's math. There aren't enough genetic counselors.
Right. Another here, several presentations today and yesterday, we've heard about the importance of selecting the right patient for the best results of whole exome sequencing. And maybe you can share with us how you approach that issue here at your clinic.
So I think when people talk about selecting the right patient, you really have to keep in mind there is no correct answer to that question. What was the right patient a year ago is not what we think is the right patient today. So fundamental to the process is to be able to constantly reevaluate what you consider to be right. So if you have to look at the parameters that are going into the decision what is right, it's patient need, it's patient expectations, and it's what we can deliver in a reasonable time to have an effect on outcomes. And so when you look at that, our first decision was, let's go after patients with advanced cancer. That was the right decision a year ago. Now, as we get better at it, that may still be the right decision, but now the right decision is to do more, to start going after different cancers earlier on. So the answer is that our boards meet every 1 to 2 weeks, and every so often we have a different meeting that happens after hours where we bring everybody together and we reevaluate our criteria. And we reevaluate our criteria, and then as a group decide whether it's time to change them. And when we do, then we expand our criteria.
And it sounds like that's a perfect segue into another question that we've gotten, which is how might you want to expand the clinic? What areas do you foresee additional services might go into in the future?
So usually when somebody asks a question like, what additional services do you foresee, they're usually hinting at, is it time to do preventative medicine genomic screening? And our answer really is based on everything we know, based on the variations we're going to find. We do not think that it is the right time yet. We still need to know how to handle the vast number of variants we're going to get in a much deeper way before we can start doing that's more meaningful. I think in between you're going to start seeing gene panels, a gene panel for example, cardiovascular risk, a gene panel, as I talked about, hereditary colorectal cancer. And those are you can deal with those a little better. We'll get to our final goal, but we're not there yet.
I remember at last year's conference, we had a number of sessions and conversations around some of the bioethics. And maybe you could, again, talk a little bit about how that area has been incorporated into some of the programs here.
You know, that's something that every academic institution, and at Mayo we're no exception, is we really want to do the right thing. And to do the right thing sometimes means that you don't do something, as sometimes it is that you do something. Having bioethics involved is essential in making that part of that decision. So what we've done is the following. Everything we've done, we've always involved on the panel, we have a bioethicist. So we meet as a Center for Individualized Medicine once a week with all the program directors. There's a program director for bioethics who's at the table. And believe me, they have no problem speaking up. We also run our clinical individualized medicine clinic at the same time offer entry to patients to different research studies. And one of the studies we're running is through our bioethics program, trying to understand patient expectations, patients' needs, what they got out of the clinic. So we're incorporating it not only in our clinical practice, but also from a research aspect.
You know, we were talking before coming out here about how rapidly patients at Mayo can get information into their patient portal, sometimes even ahead of the doctor sometimes. And there are questions here wondering if you might allow your individualized medicine clinic patients to access results from your research protocol that were not necessarily offered by the clinical lab, or even raw data.
Yeah. So there are different answers to this question, and I think a lot of us have different answers to the question. The real answer is that we're bound by our IRB protocol. So once you write what you write in the IRB protocol, you're bound by it. Our IRB protocol states that we only release results that have been confirmed by a second technique in general Sanger sequencing. So because of that, from the research grade results are not given to the patient. Is that the right thing to do? It's debatable. It's what the IRB has decided, and I can very see the reason for that. Will it be revisited as we learn more in the coming years? I have no doubt it will be, but it's not where we are at the moment.
Sure. So when you invite me back for the 10th anniversary, what is your individualized medicine program going to look like? What's your vision?
I honestly hope that we will not have a 10th conference, because it becomes so obvious that what we're doing, that every department is doing it, that why have this conference? You know, that's a little Pollyannish, will probably still be around, but I do feel that a lot of what we now consider to be cutting edge will become routine. Pharmacogenomics is a perfect example. The revolution in cancer care is another example. Those things we won't be talking about for many years more. They'll become routine parts of what we'll do. We'll be talking about some very specific, and we'll be probably moving into metabolomics, into proteomics, into many other things that we still need to do. So my vision is that our role becomes much less prominent, and we're moving on to other things.
Wonderful.